Lloyd, thank you for joining us this afternoon. I've got a lot of information to convey, and I'm eager to do it, so let's go ahead and get started. Before we begin, just a couple of quick housekeeping items. The webinar is being recorded, and a copy of it along with the slides and the resource items that I'm going to mention will be available on the AVS Medical blog page. If you've signed up for this webinar or you've signed up for our blog, you will get an automatic notification once it's up there, and you can rewatch the video and download the slides and have access to the resources that I mentioned. If you haven't signed up for the AVS Medical blog, I would strongly urge you to do so. It's an educational tool. There's no sales and marketing stuff in there. It's really just designed. It's a platform designed for us to get this type of information out to our users. So if you have time, please go to the avsmedical.com/blog and sign up for that. If you have the GoToWebinar control panel on your screen right now and it's taking up part of the screen, you can minimize that by clicking that little red box with the white arrow in it. Your phone lines are muted right now, but at the end of the webinar you can click that hand icon and I can unmute your phone lines excuse me, and answer your questions. Or if you prefer, you can type your question into the chat window there, and if you have a slightly different looking GoToWebinar control panel on your screen, instead of looking like that, it might just say questions. Just click that and you'll be able to type a question in, and we'll answer that during the webinar today. Okay, one final thought, or if you are listening via your computer speakers, you won't be able to ask me a question through your computer unless you happen to also have a microphone connected to your computer. So let's jump in. So the goal for today's webinar is to present the new CMS Quality Payment Program and to discuss how it relates to other programs such as Meaningful Use, PQRS, the Value-Based Modifier. I'm going to talk about the timing of the program, the financial aspects, the different tracks that are available to providers, something known as the pick your own pace, and then finally, and probably most importantly, I'm going to go through exactly what you need to do to succeed with these programs this year. So let's jump in. It wouldn't be a government program if they didn't give us some new acronyms to learn. So here's a quick list, and I'll start with what's known as the Quality Payment Program, or QPP. On October 14th of this year, 2016, CMS released the final rule excuse me, to what is the most significant change to the Medicare program in a generation. The Medicare Access Chip Reauthorization Act of 2015, or MACRA, was released. MACRA repeals the sustainable growth rate formula, and it replaces it with a new value-based reimbursement system called the Quality Payment Program. So MACRA was the bill, MACRA was the legislation. The output of that was the Quality Payment Program. Now, under the Quality Payment Program, there are two tracks. There is the Merit-Based Incentive Payment System, better known as MIPS, and then there is the Advanced Alternative Payment Model, and for some reason it's abbreviated as APM, not AAPM, but when you see APM, we're talking about an Advanced Alternative Payment Model. And if you're in a patient-centered medical home or an ACO right now, you're in an alternative payment model, probably not an advanced alternative payment model, but we'll talk about those in just a minute. There's a new term this year. In the past, we talked about EPs, or eligible providers, but what they've done now is they've opened up the category of people who are qualified to participate in the Quality Payment Program. So now the term is eligible clinician, or EC. So you hear me use that term as we go. And in just a moment, in fact now, I'm going to go ahead and talk about who the eligible clinicians are. So let's talk about who is defined as an eligible clinician, or an EC, under the Quality Payment Program. Essentially, any Medicare Part B participating provider is qualified under this program. That includes physicians, which would be MD, DO, DPM, DC, and DDS. So dentists are now part of this program as well. New this year, physician assistants, nurse practitioners, clinical nurse specialists, certified registered nurse anesthetists, it's a tough one for me to say, and optometrists are all part of, or are all subject to the quality payment program. And for the first 3 years of the program, occupational physical therapists, along with audiologists and speech pathologists, are exempt, but they will be included in future years in this program, in the quality payment programs. There are exceptions to the quality payment programs. So those would be if you are newly enrolled in Medicare, you are exempt. So if this is your first year of Medicare participation, you are exempt. There are both patient volume and charge volume thresholds. So if your Medicare Part B allowed charges are less than or equal to $30,000 a year, or you see fewer than 100 Medicare Part B patients per year, you would be exempt. And again, this is a Medicare program, so Medicaid providers are exempt from what we're talking about today. And if you are a Medicaid provider, what that means is you are still subject to the meaningful use rules through 2021. And of course, hospital-based providers are not included either. So they would also still fall under the meaningful use program. So I said a little in one of my first slides that the quality payment program consists of 2 tracks. And you see those 2 tracks here. The first of those 2 tracks is the merit-based incentive payment system, or MIPS. And the second is what's called the advanced alternative payment models, or APMs. And bear with me just one quick second. A little housekeeping item right here. So you can choose to follow one or the other of these 2 tracks. Most providers, though, most eligible clinicians will fall under the MIPS program. And you'll see why as we go through here. But according to CMS, their expectation is that less than 10% of eligible clinicians will follow the APM model in 2017. They expect that to change in the future, but in 2017, their expectations are that far and away most providers will follow the MIPS model. So the first part of my presentation is going to deal with MIPS, and then we'll talk about the advanced APMs a little bit later in the webinar. So let's talk about the timing. The timing is essentially now. The first performance period opens this January the 1st and closes at the end of the year, December 31st, 2017, roughly a year from today. And then by no later than March of 2018, you will submit your 2017 data. And then sometime during calendar year 2018, they haven't said when yet, you will receive feedback from Medicare on your performance for 2017. Based on your performance and how your performance relates to your peers, and we'll talk more about that in a minute, you will earn a payment adjustment that will be applied in calendar year 19. So said another way, this year, by this year I mean 2017, is the basis year for the payment adjustment in 2019. New this year are some differences in the reporting options. Under the MIPS program, you've got 2 options to report your data. You can report as an individual, as many of you always have, or this year, new this year, is the ability for you to report as a group. If you choose to report your MIPS data as an individual, your payment adjustment will be based solely on your performance. And an individual is defined as a single NPI tied to a single tax identification number. Now, if you have more than two eligible clinicians that share a common tax identification number, you can report your data as a group. However, there will be one payment adjustment applied to everyone in that group. Now, regardless of whether you submit as an individual or as a group, you will submit your data through your certified electronic health record, a registry, or a qualified clinical data registry. There is an option for the group, and they can use the CMS web interface. And if a group chooses to use that web interface, they have to register for that no later than June 30th of 2017. Now, in future years, they thought it was going to be ready this year, but it's not. But in the future, the expectation is that people will be able to form virtual groups. This is where individual clinicians or groups that have 10 or fewer eligible clinicians can band together and form a virtual group. The benefit of this is it allows individual providers or small practices to band together and submit one set of data that would cover everybody inside that virtual group. So look for that. They expect to release that in next year, 2018. Okay, so let's jump into the MIPS program. Remember, I said this is the one that most people are going to end up following. So what MIPS does is it combines three legacy Medicare programs into one. So it takes the Physician's Quality Reporting System, or PQRS, the Value-Based Modifier, or VM, and finally the Meaningful Use Program, and combines all three of those into the new MIPS program. So if in the past you've been doing Meaningful Use and PQRS and subject to the Value Modifier, 2016 is your last year. That all goes away and gets rolled up into MIPS. So let's talk a little bit about the incentives and payment adjustments that are available to eligible clinicians under the MIPS program. The payment adjustments are escalating over time. You'll notice on the slide here that the payment adjustments in 2017 range anywhere from a -4% to a +4%, depending upon something known as the clinician's MIPS composite score. And we'll talk about the MIPS composite score in just a few minutes. But you can see each year that payment steadily adjusts. Now, there's an interesting thing about the payment adjustments, or about this program in general. It is a budget neutral program. And what that means is that for every incentive dollar that's paid out to a well-performing, let me say it that way, a clinician who's doing a good job and is performing well, every dollar that they earn is going to be taken from another clinician who is not doing well and who is subject to that -4%. So you have to think of this really as a competition. You're going to be competing against other clinicians to earn these incentives, and CMS is counting on the fact that there will be a fair number of clinicians that don't participate or don't do a good job of participating, and there'll be enough penalty money out there to fund the incentive money. Now, they do have what's known as a multiplier factor of up to 3 times that they will apply to the stimulus payment side of things only. Well, that's not true. They have an adjustment modifier of up to 3 times. So instead of 4% this year, it is theoretically possible that could be as high as 12%. However, it is unlikely that will happen because, again, going back to that budget neutrality, if you had a superstar, super high performing clinician who qualified for that 3 times incentive, you'd have to have another clinician who was doing that as bad a job on the other end of the spectrum. So they don't expect that that's really going to happen. However, if you look down at the very bottom right-hand corner of that slide, they do have something called an exceptional performance bonus available of up to 10%. Now, that is not tied to the budget neutrality issue. They've set aside $500 million to fund this bonus of up to 10%. So for those high achievers, those that have the very highest MIPS composite scores, will be eligible for that bonus payment. So there's a lot of money available under this program if you are successful with it. So on one of the very first slides, I talked about something, a term called Pick Your Pace. And Pick Your Pace came about late last year after getting feedback from the medical community about the MIPS program. They felt like there needed to be a transition year in between meaningful use and the full-on impact of MIPS. So they've made 2017 what they call a transition year, and they have a program called Pick Your Pace, and it's Pick Your Pace of participation. So looking left to right, you've got 4 different options this year that you can choose to do. The first option, shown on the far left side in red there, is to not participate at all. You don't have to, and if you choose this option, what's going to happen is you're just automatically going to get that negative 4% adjustment. So there's just, it just happens. So you can ignore it, and that's the consequences. You'll get that negative 4% payment. The second participation option is something that they call the test model or test mode. And in the test option, you need to submit something, and even a very minimum amount of, say, 1 quality measure or 1 practice improvement activity anytime during 2017. So if on December 31st of next year of 2017, you realize, oh gosh, we forgot to do anything, you can just do a very little amount, and what will happen is you'll stay neutral. You won't get that 4%. Doing even a minimum amount will keep you from getting that negative 4%, but you won't get a positive adjustment either. You'll just stay neutral. The third option in the Pick Your Pace program is to submit a partial amount of data for a minimum of 90 days. And I'll go through what is required under that program. But there's a catch here. There's a catch to those 90 days, and I'll talk about that in the slide after next. Just remember that. And then the final option is what they really hope that everybody does, which is submit as much data as you can for the entire 12-month period. By doing that, you will maximize your MIPS composite score, which means you will maximize your positive payment adjustment, and you will be subject to that additional 10% bonus. So a lot of money available if you jump on this and start right away in 2017 and follow the program. So a couple of times now I've talked about something called the MIPS composite score. Under the MIPS program, each eligible clinician is going to receive a MIPS composite score. Now the score is based on a scale from 1 to 100 points, and those points come from each of the 4 categories listed below. So there are 4 categories that make up MIPS. And in 2017, it's the first category, the first component is the quality category. So this is the old PQRS. Quality is what we used to call PQRS. You can see that 60% or 60 points out of the 100 falls on the side of quality. Cost is the old value-based modifier. The cost category has replaced the value-based modifier category. In 2017, that has no impact on your composite score, so you see it there as 0%. The third category is something entirely new. This is the practice improvement activities, and I'm going to get into what those are, or more about that here in just a few minutes. But that provides you with 15% or 15 points of your total 100. And then lastly, we have advancing care information. Now, advancing care information is the old meaningful use program. It's been streamlined. There aren't as many things you have to do here for this, but advancing care information is the old meaningful use program. Now you may look at that and think, oh, 1 to 100, and these things total up to 100, so it looks pretty straightforward. It is the MIPS composite score is very complex. It is not a simple linear formula. Each one of these 4 or 3 categories, so if we exclude cost, has their own separate and different scoring methodologies. So there are scores within scores, and they're different for each of these categories. It becomes very complex, and an in-depth discussion exceeds the scope of today's webinar. However, I will give you some examples, and I will just say again that the more data that you submit and the longer you submit that data, the higher your MIPS score, the higher your reimbursement. So that's kind of the takeaway from this. At the end of the webinar, there's a resource slide, and on that resource slide is a link to a guide on how to calculate, or how your MIPS score will be calculated. To give you an idea, it's 50 pages long. So that's why I keep going back to this idea that more is better. More data, more time, more money. So this slide shows how the composite score changes depending on how much data you submit and for how long you submit that data. Please note that you have to submit data on at least 50% of your patients, and that's from all payers, not just Medicare payers. And so here's that catch. Remember the slide before last, I said there was a catch to those 90 days, and this is the catch. You have to submit data for a minimum of 90 days if you want to participate with MIPS at all. So, but if you don't, let me say it another way. It is a very, very high likelihood that those 90 days will not capture 50% of the patients that you see in your practice for the entire year. So when they say 50% of the patients, they mean everybody that you see during 2017. So it's very unlikely that you're going to see all 50% of those patients in 90 days, unless you're extraordinarily busy for the first for 90 days during 2017. So there is a catch there, and that's why, again, why we say submit your data for a longer period of time. So if you look at that graph, and I apologize that's a little bit fuzzy, but if you look at the intersection there of the X and the Y axis, we sort of see that negative 4%. So doing nothing, you get that 4%. You also see that performance threshold of 3 points. That's what that 3 means, 3 points on your MIPS score. Submitting anything, remember that first test track, submitting anything gives you those 3 points, and you get $0 for it, but you also don't get that negative payment. I won't go through the rest of that score, but basically what it means on the x-axis there, as you get out further towards 100, the more data you submit and the longer you submit it, the higher your score. I've said that a couple times and don't need to repeat it. But okay, so let's now jump into these 3 elements that we talked about: quality, practice improvement activities, and advancing care information. So the first one I'm going to talk about is quality. So this is the, remember, this is the highest percentage of the 3. This counts for 60 points or 60%. In order to meet this objective, you're going to need to submit data on 6 clinical quality measures or 1 outcome measure. Now, if you've been doing meaningful use, you know what the clinical quality measures are. You've been doing them for a couple of years. Or if you don't want to do that in your group, you can submit data on 11 measures. And that G-Pro web interface is the one I talked about earlier. You would need to register for that by June 30. Or if you're a specialist, there are specialty measure sets. So an example, if you're a neurologist or an orthopedic surgeon, you can go into your specialty and they will show you pre-set up specialty measures that you can do. But one caveat here, if you choose a specialty measure set, there might be 10, there might be 15, there might be 8. It just depends on the specialty. You need to do all of those measures that are part of that specialty measure set. So again, what you have to do to get credit for this one is submit data on 6 clinical quality measures plus 1 outcome measure. Now, the scoring on these measures are different than what we've seen before. Scoring is now based on a decile scale. So if you are if statistics is your thing, or you remember your statistics 101 class, then decile scales are probably familiar to you. But if not, I'll try my best to explain how it works. But each eligible clinician is going to be graded against a benchmark, and the benchmarks are set from data gathered from all providers across the country. Let me give you an example. Let's say, and one of the clinical quality measures that a lot of people are familiar with is the tobacco cessation clinical quality measure. Let's say you've got 90% of your patients are in your numerator for tobacco cessation, which is really good. But let's say your 90% falls in the 80th decile against all providers nationwide. So they're all doing a little bit better than you, and your 90% falls in the national 80th decile. What that means is you're going to get 8 points rather than 9. So that's what we mean about the A, the complexity of the scoring, and B, the idea that you're being compared to your peers. Excuse me. And again, you have to submit this data on 50% of your patients seen. That's all payers, not just Medicare payers, and it's 50% of all patients for the entire year. Again, that bears repeating. And last point I'll make about that is that percentage category rises in 2018 to 60%. So I don't think we have a lot of time here because I'm looking and I've already gone through about half of this. I do want to show you, I'll pull this over so I think we can see it, and I'll talk more about this at the end, but CMS has put together, and you don't have to write this down, it's going to be in the slide deck, but they put together a fantastic website called qpp.cms.gov, and when you get into this, it really explains everything. I've stolen some of their graphics, as you can see, but as you get into here, and we talk about the different models, it will go through and it will show you, so I'm jumping around a little bit here, I want to get to the quality measures. It will show you exactly which measures are available. So here they are. Let me just show you these real quick. So you can come in, they've got 271 quality measures, and you can search in here by keyword, search whether it's a high priority or not, what your data submission will be. For most of you, it'll be EHR. And then these are the specialty measure sets. So you can go in here and choose which measures you're going to submit data on. As you click in each one of these, it'll tell you exactly what you need to do and give you all the information about it. So there is a link. I have a link to this in your slide deck, and you will get that. So I know I'm throwing out a lot of things here, and I don't want you to get concerned that you may not know what these are. So that is the quality scoring component. The second component of your MIPS score is going to be the advancing care information. This one is the old EHR program. This replaces the all or nothing meaningful use program to what's thought of as a continuous scoring system, where once again your measures are compared to benchmarks much the same way that they were in the quality category that we just talked about. The ACI, or Advancing Care Information, accounts for 25% or 25 points of your total MIPS composite score. And I'll get into that in just a minute. In this category, there are a total of 155 points available, but in order for you to get all 25%, in other words, in order for you to get full credit for the Advancing Care Information, you only need to get 100 points in this category. So remember a moment ago I said there's scoring within scoring. This is what I was talking about. So I'll give you an example of this in a minute. It might make it a little bit clearer. There are additional bonus points of 5% for reporting to a registry in addition to an immunization registry. In other words, you still have to submit to an immunization registry, but if you submit to another one as well, like syndromic surveillance or a cancer registry, you get an additional 5%. And then there is a 10% bonus for using a certified EHR. That one's a gimme because one of the requirements is that you use a certified EHR, so they give you a bonus for meeting the requirement. There are a total of 5 required measures that must be submitted. And if you've been doing meaningful use, these look very familiar to you. So the 5 that are required are the security risk analysis, e-prescribing, providing patient access, which is the patient web portal, sending a summary of care, and then requesting or accepting a summary of care. You can also choose to submit up to 9 other alternative measures. Excuse me, not alternative measures. You have to submit those 5, but you could submit up to 9 more for additional credit. And I'll show you what I mean by that in just a second here. Let's get over to it. So here's how your ACI score is calculated. So again, we talked about quality of scoring a minute ago. Now we're talking about the ACI score. You have a base score, which gives you a total of 50 points. So by submitting those 5 measures we just talked about, you get the base score of 50 points. You'll receive that for attesting successfully for those 5 measures. On top of that is a performance component that has a value of up to 90 points. Now the performance piece is similar to what we saw a moment ago with the quality scoring, where points are accumulated by decile group. And again, you're ranked to nationwide benchmarks. And then lastly, we see those 15 bonus points that are available by submitting to a public health registry in addition to immunizations, an immunization registry, and by using an EHR. So if you hit all of those things, you get that minimum 100 points. And by getting those minimum 100 points, you would get all 25% or 25 points for the ACI score. Now, don't shoot the messenger, folks. I didn't make this up. This is CMS's program, so it does get confusing. But to say it again, if you get 100 points in your ACI score, you'll get all 25 points that the ACI category represents for your total composite score. So that is the second of the 3 categories that we're going to talk about. The third one is the clinical practice improvement, and these are the key elements that go into this category. So this is that completely new category. You have a very wide variety of things to select from. This slide is showing you the 9 subcategories, but in each one of these subcategories, you've got approximately, some have 9, some have 11, most of them have 10 different activities that you can actually report on. So, and when you get in and look at these, you're going to find that a lot of these are things that you're already doing. These activities are very similar to a patient-centered medical home, or PCMH. So if you are part of a PCMH now, this category is going to be very easy for you to achieve success in. So this category accounts for 15% of your MIPS score. Now most eligible clinicians will report on a total of 4 practice improvement activities. Those activities are characterized as either high value or medium value. And you can see from the grid here on the left that if you are an individual or a group, in order to get the full 15% credit towards your MIPS score, you need to rack up 40 points in the practice improvement activities. And the way that you do that is by accomplishing those practice improvement activities that I talked about a minute ago. So you've got to get a total of 40. Now, if they're high value activities, those are worth 20 points. So you might only have to do 2, or you can do a mix. You can do 4 medium value activities to get the 40, or a combination of medium and high. But the key is you've got to get to 40. And that same website I showed you a moment ago, the qpp.gov, that lists what those practice improvement activities are. So that's where you find what they are. Excuse me. Cost category, once again, I'm not really going to talk about this because it has no impact on your MIPS score in 2017. But I will restate that this replaces the value-based modifier, and that in 2017, CMS will still provide feedback via your QRUR reports, but this has no impact on your 2019 payments. And if you've been participating in the PQRS program, you know where those QRUR reports are. Okay, so that's MIPS. And again, MIPS is those 3 things you have to do: quality, advancing care, and practice improvement activities. Those 3 subcategories make up MIPS. Now the other track, we started out by talking about 2 different tracks. MIPS was the first track. The second track is participating in an advanced alternative payment model, or APM. So I'm just going to talk about the advanced alternative payment model as APM. And an advanced APM is a subset of the more traditional alternative payment models. And as I stated earlier, by far an overwhelming majority of clinicians are going to fall under the MIPS program, with very few qualifying under the advanced alternative payment model. But I'm going to go through it here and give you an idea of the different options that are available to you. So, a couple thoughts. If you can qualify under an advanced alternative payment model, you are exempt from all of those MIPS requirements that I just went through. So that's the benefit, or one of the benefits of participating in an APM, is that you're exempt from the MIPS requirements. In order to qualify to be part of an advanced APM, let me say it another way. In order to qualify as advanced, CMS has to give your APM that designation. And I'll show you a list of those in just a moment. If you participate in an advanced APM, you will submit quality measures that are very comparable to the measures we just saw in MIPS. They're different, but they're very comparable. You are still required to use a certified electronic health record. And here's the key, is that in an advanced alternative payment model, you have to bear more than a nominal financial risk. So that's really what distinguishes it. As an example, a Medicare Shared Savings Plan Track 2 or Track 3 qualify because those ACOs, the providers bear more than what they call nominal financial risk. But a Track 1 Medicare Shared Savings Plan does not. So a Medicare Track 1 is not considered an advanced alternative payment model, although Tracks 2 and 3 are. You have to participate for at least a year in an advanced APM to become what's known as a qualifying provider or QP. There are minimum thresholds, both of percentage of payments and percentage of patients that are enrolled in the APM that also have to be met. I'll talk about those in a minute. If you don't meet those thresholds, but you're still above a certain minimum threshold, you can be designated as what's known as a partial qualified provider. Okay. So if you do participate successfully in an advanced alternative payment model, you will receive a 5% lump sum bonus payment starting in 2019 and getting that each year through 2024. And again, you're exempt from those MIPS payment adjustments. A couple other comments about the advanced alternative payment model. All of the eligible clinicians in the advanced alternative payment model will be assessed together. CMS will calculate your threshold score based on your Medicare Part B allowable charges or the count of Medicare beneficiaries that are attributed to the APM. And the final bullet point says that it will determine which APMs are advanced by January the 1st. They've already done that, and I'll show you the list of those in just a second. Taking a look at the both payment and participation requirements here. Again, this graphic is a little bit fuzzy, but you can see that this is it's an increasing scale. So if you look at your payment years there, so 2017 is your basis year for this, and I'll explain more about that in a minute. But the payment year will be 2019. So you can see the minimum payment percentage is 25 in 2019, going all the way up to 75% in 2024. And then also, that's also true on the patient count. Starts out at 20, but it goes up as high as 50% in 2024. So that's an increasing scale of both payment and patient participation. So again, you would qualified participants would receive a 5% bonus if you're fully qualified. 2017 is the performance year, and 2019 is the payment year. That year in between, 2018, that's what they call the services payment year. That's the basis for your payment in 2019. A little confusing, but so let me just kind of walk you through it. So in 2017, um, your status will be based on that advanced alternative payment model begins this year or in 2017. So what you do is you're part of the advanced APM in 2017. In 2018, CMS will look at all of your payments. They'll assess your charges in 2018, and then based on your 2018 charges, you'll get a 5% lump sum in 2019. So unlike under MIPS, where you get a 4% increase in your payments, under the advanced APM, you get a lump sum payment of 5%. Okay. So once again, 2017 is your basis year. If you're successful in 2017, if you successfully meet the requirements of an advanced APM in 2017, they'll look at your charges in 2018, figure out how much you're going to get, and then give you that payment in 2019. So here's that list of advanced APMs that I talked about a minute ago. As of now, these are the only ones. So comprehensive end-stage renal disease care model LDO arrangement and non-LDO arrangement qualify. If you are part of the CPC Plus program, that qualifies. That's probably the easiest one. Unfortunately, if you're not already registered in the CPC Plus, they have closed the registration for that. As I stated a little bit earlier, the Shared Savings Program Track 2 and Track 3, not Track 1, qualify. Next Generation ACO and an oncology care model with two-sided risk, that qualifies as well. It is CMS's stated goal that they do want to open up the number of APMs qualified as advanced. And so starting in 2018, they will. And I believe that they are also looking at possibly reopening the CPC Plus program, if not this year, certainly in 2018. So we're coming up quick on the end of the webinar here. Here is a list of the resources that are available to you. Again, you'll have this in the slide deck and in, of course, the video. That first one, that's a clickable link to that CMS Quality Payment Program website. The second one is a link to download the MIPS scoring overview. It'll walk you through all the different models there. The other great resource available to you, again, is the AVS Medical Blog, and that is there as an educational resource. It's not a sales or marketing vehicle. Please subscribe to that if you're not subscribed to it now. You'll get instant updates and information about future webinars. And then lastly, about half the folks on the webinar today have my email address, but the other half are new users. So that's me. Feel free to email me. I'll do my best to get you answers to your questions if you don't ask them today. Before I open it up for questions, I do want to just say one thing, and that is about half of the people on the webinar today are current EHR users of ours, but there's a fair number of people on the webinar today who are not. So I will, shamelessly say that AVS does have both cloud-based and server-based EHRs. If you don't have one today and need one because you want to begin this program, please give us a call or email once the webinar is over. So that said, let me go ahead and open it up to questions. Again, you can click that little hand icon, and I can try and answer your question, or I will answer them through the chat window, which we've got quite a few in here already. So I'm going to just answer the ones that are in here. Yeah. So this first one is a good one. It says this gentleman participates with Medicare, but he still sees Medicaid patients. Is he exempt? No, unfortunately, it's the opposite. You have to comply with both. So you have to comply with MIPS and Medicaid. Now, the only way you would have to comply with the Medicaid would be if you have a patient volume of 30% of your patients or more are Medicaid. So I don't think that qualifies as you. So the unfortunate reality here is if you are both Medicare and Medicaid, you've got to do both programs. The next question is when would you submit this data? Um, you have to submit the data after January 1st of 2017. So I think this question um, may be asking if you're not planning on participating for the entire 12 months, could you attest earlier in 2017 or submit your data earlier? No, you have to wait till after the end of the year to submit the data, even if you're not doing the full year. Another good question. Should a pulmonologist, but I think this applies to anybody, should a pulmonologist go with a specialty set of those quality measures or not? I don't know the answer to that. I think the answer is to go to that website and look at the quality measures that are available, and then look at the ones that are available under the pulmonology specialty and decide if A, there are fewer, or B, they're easier. But then there's also a third part of that is um, you've got to make sure that the quality measure you want to do is in your EHR as well. So that's got to be part of it. But the short answer to your question is I would just look at all the measures that are available and see which ones make the most sense for you. Here's a good question. Do cash pay patients count as part of your total patients seen? Yes, they would. Yeah, because it's going to, the reporting in all of these programs, to the government programs, the reporting is all comes out of your certified EHR. So if the patients are on the schedule, then they're in the data. They're in the statistics. So yes. Um, but if they're not, if they're walk-ins and they're not on the schedule, then no, they wouldn't be. Good question. Patient threshold only is that only for Medicare or is it all patients? It's all patients, right? So the program is Medicare. It's a Medicare program. It's based on Medicare charges, but it's all patients. They do not have to be Medicare patients. And so for right now, that's all the questions that we have. Okay, well, I don't really see any other questions here coming in, so I'm going to pad for time here for a few seconds, and then I'll go ahead and wrap it up. We're coming up fairly quick on the hour. I tried to go slow through that because I know there's a lot of information in there, particularly around that scoring. I made kind of an offhand comment to one of the folks here at AVS during lunch that I'm not sure if they intended to make it as difficult as they did to figure out the scoring, but if they were intending to make it difficult, they did a good job because it's complex and it doesn't need to be that complex, I don't think, but maybe those folks are probably smarter than I am and they know what they're doing, but it does seem overly complex. I think the takeaway message is that it really is easy. This is easier to do than meaningful use. And PQRS and value-based modifier puts it onto one nice package. And if you do it for the full year, you're going to A, maximize your money, and B, be ready for next year when you will have to do it for the entire year. So good question coming in from one of our current EHR users asking when the measures will be put in our system. Any day. I don't have a better answer for you than that I'm asking. And I don't see any other questions here in the system. I will go ahead and wrap it up. Please feel free to email me directly or call. I think everybody here, well, a lot of folks are new here, so AVS Medical 877-975-9160. Please give us a call. This is a good question, though. It just popped up. If you, I I'm not sure I fully understand that, but if there's a particular specialty measure that you want to report on, can you put that in the software? And I apologize if that's not the right question, or I didn't understand that correctly, but you can't put it in the EHR. Um, that would have to be done by the manufacturer, but you could still report on it outside of the EHR, although that would be, you could, you don't have to use the EHR to report the quality measures, but it makes it substantially easier to do. So in your case, a neurology specific measure, if it's one we don't have in our EHR, you could report it outside of the EHR. You would just have to do it through a qualified clinical data registry. There might be a small cost for that. I know some of them do it for a few $100s I've seen in the past, but you could do that if you. Okay, well, um, I think that pretty much wraps it up. I don't see anything else coming in the system here. So I'm going to go ahead and wrap it up. Again, please feel free to email me. I will do my best to get back to you right away. Thank you once again. I hope it was of some use to everybody. Bye now.